Welcome to the Alberta Transplant Institute seminar, our Wednesday midday seminar. We'd like to acknowledge that the University of Alberta is located on Treaty 6 territory, and we respect the histories, languages, and cultures of all of our First Nations, Métis, Inuit, and other First Peoples of Canada. And we recognize their continued contributions to our community, and we're very pleased to be amongst them. We'd also like to thank Paladin for their continued support of the ATI seminar series, which has been very helpful and very welcomed. So today we'll be featuring two speakers who are going to be discussing a topic of important global interest, which is equitable access to kidney transplantation throughout the world. Our first speaker is Dr. Aminu Bello, who is professor in the Division of Nephrology and Immunology here at the University of Alberta. He qualified as a medical doctor in Nigeria and then underwent subsequent specialist training in internal medicine and nephrology in Nigeria, in the UK, and finally in Canada, here in Canada. He also completed his PhD and then even more training as a postdoctoral clinical and research fellow in nephrology here at the University of Alberta. He's a member of the Alberta Kidney Disease Network, which is a successful and well-established team of scientists, healthcare policymakers, clinical leaders, educators, and knowledge translation experts studying health services solutions to reduce the burden of chronic kidney disease and other chronic diseases. And he's very well published and has keen interest in global health initiatives to improve nephrology practice and education in emerging nations. Our second speaker will be Dr. Okpechi, also an MD PhD. He's an honorary professor of medicine at the University of Cape Town and was the former head of nephrology and the director of the Kidney and Hypertension Research Unit at the University of Cape Town. He's a member of the International Society of Nephrology Global Kidney Health Atlas, and he's also working both here at the University of Alberta as well as in Calgary. And so we're very, please join me in welcoming our two speakers who will be presenting Capacity and Access to Kidney Transplantation, Where the World Stands in 2023. Welcome.
Thank you. Thank you very much.
Thank you very much
for that great presentation.
I think we start with you, Dr. Bello. Yes.
Okay.
Yeah.
All right.
All right. So thank you, and thank you for inviting us to be here this afternoon to share our data with you on capacity and access to kidney transplantation globally, based on a project where we've been conducting with the International Society of Nephrology. So the key goal today is, over the next 45 minutes, to go through with you the status of kidney transplantation in terms of capacity access and financing as well across the various world regions and countries. And we are going to discuss the various challenges across the world regions, particularly low-income countries, and hopefully some opportunities to effect a change. And hopefully you understand the relationship between healthcare organization and funding and capacity for kidney transplantation, and particularly in low-income countries as well. So this is based on data generated through a project under the umbrella of the International Society of Nephrology called the ISN-Global Kidney Health Atlas, which is a multinational cross-sectional survey designed to assess and also monitor capacity for kidney care across the spectrum in terms of availability, access, and financing across all countries of the world. It started in 2015 with the first report published in 2017. Then we conducted another iteration that focused on kidney care in advanced kidney disease, meaning capacity for kidney care in dialysis and kidney transplantation. Then that was repeated again in about 4 years. So now the plan is it will be going in a 4-year cycle. so that we can assess the progress made by countries in improving kidney care around the world. The basic framework strategy is based on what is highlighted on this slide, essentially to capture data on core elements of optimal care for kidney disease. Of course, it's a framework we leverage from WHO, assessing capacity for kidney care for chronic diseases like diabetes, heart disease, and now for the first time, we developed that and adapted it for kidney disease care in terms of various domains of funding. The main rationale is actually to improve the understanding of the variation across the globe, across the world region in terms of their income status, as well as within region variation in capacities of countries to deliver kidney care. And hopefully this information can be used by policymakers to advocate for kidney care around world countries and region. And it's in keeping with the mission of the global organization, the ISN, which is the International Society of Nephrology. So it's research. So that the key question is, how can we improve global capacity for kidney care? But the ISN wanted to the gaps defined so that they can use that information to work with other international stakeholders, such as WHO, the World Bank, to advocate for kidney disease funding across countries of the world, particularly the low-income countries, so that they can use that data to develop high-quality kidney care programs, including transplantation. So the IK will go through the detail of the survey, but we work with WHO and work with the framework, the pillars of effective health system, covering all the core pillars, 6 there: service delivery, workforce, information system, access to medicine, health financing, leadership and governance. So we use that to develop this, the concept of the project, as well as the tool for collating information over all the iteration conducted over the last 7 years. So like I said, it's across the spectrum. So we're looking to collect data for kidney disease care, from acute kidney injury to early CKD, dialysis, kidney transplantation, conservative kidney management. So we are collecting information in various domains that will inform policymaking at global, regional, as well as individual country level. So we've been very lucky, and the response from the countries across the world has been quite encouraging. Almost all world countries, about 167, representing over 90% of global population, have been represented in this exercise. So like the key aim is to really define, having a global standard, defining capacity for kidney care in terms of structures in managing kidney disease or patients with kidney disease across the spectrum, from early CKD to dialysis to transplantation, and also non-dialytic conservative management of kidney failure. And the next is now Dr. Okpechi will go through the specific data regarding the project, on how we collected information regarding capacity and readiness of nation to provide kidney transplantation in its various facets. Dr. Okpechi.
All right, thank you very much, Aminu, and thank you, Dr. West, and thank you to the ATI team for inviting Aminu and myself to present our data to the team today. As Aminu mentioned, the ISN-Global Kidney Health Atlas has been going on for the past 8 years, and we just recently completed the 3rd iteration of the Global Kidney Health Atlas. And each one has been a success in being able to be provide global framework or global overview or picture of what is happening in terms of various facets of kidney disease management and care across the world. As Aminu mentioned, the ISN Global Kidney Health Atlas was designed, around 6 frameworks of the WHO. One is service delivery, the other one is availability of workforce and what type of workforce is available. The other is health information systems that can be used, access to essential medicines, health systems, financing, and leadership and governance, including advocacy for different facets of care. For us in nephrology, obviously, at the end of the day, we have pre-dialysis care of patients, but when patients develop kidney failure, there are 4 pathways to go, really. It's either they get hemodialysis, peritoneal dialysis, kidney transplantation, or in some instances, conservative care management will be the way to go for patients. And for every one of these facets, whether hemodialysis or one of these treatment modalities, either hemodialysis, PD, transplant, conservative care, in their approach to the Global Kidney Health Atlas, we applied all of these frameworks of building blocks of the WHO in defining or discussing elements of care that is available to patients across the world. Obviously, we're talking to the Alberta Transplant Institute. We're not going to talk about hemodialysis or conservative care. We're going to focus on kidney transplants again. So if you think about it, we are only taking data regarding kidney transplant from our survey or from the work done across these different building blocks of the WHO, and which is what we will do. But I think to be able to give us a good understanding of what we found in our survey and in our study, it's good to begin by providing some sort of background information around what we know so far about kidney transplantation from different parts of the world, from different countries, including Canada, including Nigeria, where Aminu and I originally come from. And that will give us an idea of the spread of availability, of accessibility, of affordability, of metrics of care for kidney transplant. We know that kidney transplant is the gold standard of treatment for kidney failure, as it has superior survival and quality of life compared to either peritoneal or hemodialysis. But just a short journey around kidney transplantation. We know that in 1954, the first successful kidney transplant took place. Then over a decade later, there was the announcement of the first simultaneous kidney and pancreas transplant. And there was the first successful liver transplant a year later. A year later, again, there was the first successful isolated pancreas transplant and first successful heart transplant. Christian Barnard is featured here, and the reason I put him here is he worked in the same hospital. I used to work in South Africa and was the first person to successfully implant a heart to someone who had a failing heart. In 1981, first successful heart-lung transplant. And in 1983, cyclosporine was introduced, and this began to change the landscape of transplantation in terms of availability of treatment that is effective more than what was available before. And the same year was the first successful single lung transplant that had happened. And in 1987 was the first successful intestinal transplant. And of course, all of this now is history. Transplantation has been going on very strongly ever since then. If we look at the current and projected, the current and future landscape of kidney replacement therapies, we find that many countries, especially in some countries in Latin America, most countries in Africa, most countries in Southeast Asia and in the Pacific region, do not really have much access to KRT. From 2010 to 2030, in 2010, the number of people receiving KRT was 2.6 million worldwide, whereas it was projected that the number of people needing it was 9.7 million, with a gap of 7.1 million people who are unable to access it. And of course, this projection goes on to be a gap of about 9 million people or more in 2030. Out of these 2.6 million people, sorry, I need to take this, it's covering me, yeah, I can see better now. Yeah, out of these 2.6 million people, only 22% were kidney transplant patients. And again, of course, if we project that the same pattern is going to hold going forward to 2030 and beyond, we find that only a few people have access or are able to receive the treatment that has the best prognosis for them in terms of quality of life and outcomes. The incidence of KRT in rich countries, so I'll put it that way here, and you will see why I stated this. For instance, in the US, we've seen a continual increase in the number of people who receive in-center hemodialysis from 2000 to 2019, rising by about 34.5%. And the same thing has happened with kidney transplantation. The number of people receiving kidney transplantation based on USRDS data has also steadily increased by about the same amount, 34.3% between 2000 and 2019. And in Canada, the number of dialysis patients have increased by about 15% in, between 1981 and 2019. But the number of people receiving kidney transplantation or who have a functioning kidney transplant has increased by more than 30% in that period. If we contrast this to countries that are not high-income countries that we have data on, we find almost the opposite happening. So in South Africa, South Africa is one out of probably a handful of countries in the entire African continent that have capacity for kidney transplantation. Between 2000 and 2015, this number actually represents the total number of transplants that occurred in the entire country then, 360 transplants happening in the early 2000s, and this steadily declining in 2015 to 285 transplants, a reduction of about 21%. And in 2018, data showed that this had actually declined further to 236, which is a decline of almost 34.5%. We remember the data I showed earlier. This is increasing by 34%, as Canada is increasing by more than 30%. In Africa and countries similar to this, there is almost a threefold reduction, a third reduction in the number of people having access to transplantation or in the public service. And one of the reasons for this in South Africa specifically is the number of private sector KRT providers has more than quadrupled in a decade in South Africa. You will see that the number of people who are granted hemodialysis, and I use granted for a reason because South Africa rations treatment for KRT, who are given access to hemodialysis, it's only 762, and this is 2020 data in public sector, whereas this is over 5,000 in the public sector. And transplant patients account for almost 1,000 in the public and nearly 900 in public sector. So a lot of these patients who were previously receiving their transplant in the public sector have been diverted, so to speak, to the private sector, and reduced funding in public sector healthcare has also contributed significantly to this. Again, if we look at worldwide distribution of solid organ transplantation, this is data from 2015. This is the African region, the Americas, Eastern Mediterranean region, European region, Southeast Asia region. There are only 7 countries as of 2015 that had capacity for kidney transplantation in the entire African region. And the total number of transplants they contributed that year based on available data was less than 500 compared to 21 countries in the Americas. That was almost 32,000, 47 countries in Europe. That was over 26,000 kidney transplants. And when we look at those countries and the proportion of patients who live within those countries that where transplantations happen, about 40% of patients. And what this means in reverse is that 60% of patients live outside of countries where there is any access to kidney transplantation in Africa. And if you look at other regions, most patients live within a location or province or country where kidney transplants do happen. And of course, the rest of the data just shows other transplants, which I know Alberta Transplant Institute will be interested in, but we are only focusing on kidney transplant today. There are several barriers we know that are barriers to kidney transplantation, both medical and non-medical barriers. The medical barriers are, pretty well, well known to us. But if we look at non-medical barriers, if we look at the patient level, there is a lack of knowledge about what transplantation is about. There are fears and concerns that are often reported by patients, either fear of rejection or graft failure, fear of the surgery itself, fear of medication or adverse events, and fear of the living donor's health, all contribute to barriers to kidney transplantation. Obviously, something we will notice here is also the cost of transplantation featuring up as a barrier for patients, and we'll talk about this soon, and religious reasons that oppose transplantation, as including all of these barriers that are mentioned here. But at the healthcare profession level, there is the attitude, the role of perception, motivation by the healthcare professional. Again, if you remember the data I just showed about how ART is provided in South Africa, most of it has moved on to private care. And in private care, most patients are left on hemodialysis, particularly I think because of reimbursement. But there is also lack of knowledge, lack of expertise in terms of availability of surgeons and physicians and nephrologists to be able to look after patients who have been transplanted. And if we look more broadly at the healthcare system level, we find that financial barriers, lack of availability of support staff, all play a role in creating non-medical barriers to transplantation. If we look at the issue of cost, the cost of kidney transplantation varies widely, and it depends on how it is reported, whether it's the direct cost of the surgery itself, whether it's the cost of the surgery plus medications. For instance, in the United States, the median cost of kidney transplantation with medications for the first year is over $65,000 US. In the European Union and in England, between 2015 and 2005 and 2015, first year cost of kidney transplant, which included the cost of the surgery itself, was between $40,000 in Spain and $61,000 in Germany. In Canada, we could find data, I think this was from 2007, where they report that the cost of first year of kidney transplantation in 2000 was about 76,000 Canadian dollars. And for subsequent years with a functioning graft, this was about 25,000 Canadian dollars. The one thing that is common for these three countries, regions, is that public health funding or some sort of public reimbursement is available to pay for this cost of transplantation in these countries. And what usually accounts for most of the cost of transplantation, based on this data from the USRDS, is the cost of immunosuppression, which is over $6,000 for 1 year of use of immunosuppression and treatment for CMV, including hospital fees and medication, which will account for over $6,000. In Europe, immunosuppression also accounts for almost over a third of the cost of transplantation, but post-transplant events that will require hospitalization or some sort of intervention may account for close to 25% of the overall cost of transplant over a 3-year period. If we look at country spending patterns, so total health expenditure per person per year, 2013 and 2015. This is 2013 data, I believe, for Sweden, for Canada, and for Netherlands. So this is how much the government will spend per person per year. Almost all similar, almost 7,000 US dollars in these countries. This is the proportion that is paid for by private, 15%, 85% public fund. In Canada, 30%, 70% public, and same in Netherlands. If we look at the spectrum of African countries and the health expenditure in 1995, so here is the overall health expenditure per person in Africa in 1995, that's $95. And in 2013, it was $222, which is a massive increase of 134%. But this goes nowhere to be able to match what is available in high-income countries. Obviously, there are a few countries in Africa that, well, break the $1,000 threshold, if you like, but still that is very minimal. If you look at Nigeria, and again, I think it's easy for me to point out Nigeria. I am from Nigeria, so I know what is happening there. Aminu is from Nigeria, so it doesn't look like one is biased in any way. This was a paper from Nigeria in 2017, where they looked at the cost of transplantation for people with kidney failure. They went to India to get a kidney transplant. It was about 18,000 US dollars. The average minimum wage of a Nigerian civil servant is less than $1,000 per annum, actually, less than $1,500 per annum. And a kidney transplant, 18,000 US dollars in India. In Nigeria, it's 32,000, and so on and so forth. And this is the breakdown of who bears the cost of kidney transplant. We find that close to 77% is borne between the family and the individual, with government only playing involved in 3% of cases. This is a village in Nepal where most people, over 90% of people actually, it is said, live with one kidney, and there's so much poverty there. Many of them travel down south to India, to Chennai, where they sell a kidney for between $100 and 3,000 US dollars. And for these people, this scar that they bear is the cost of kidney transplantation for them. This recently happened. You can see this is May 2023. Again, this is a 7 Nigerian senator. Because of lack of access to transplant or availability of transplantation in Nigeria, in parts of Africa, he has a daughter who developed kidney failure, and he was jailed, long story short, in the UK for 9 years because of plotting to harvest organ from someone. And this was published in the American Journal of Transplant in 2022. Some people paved with their lives for others to be able to have access to transplantation. And this was a report of breaching dead donor rule in China, where there was evidence in 71 cases that it wasn't, the method of brain death could not be properly declared or ascertained in many of these people who had their organs removed for transplantation. When we look at the attitude and knowledge towards kidney transplantation across cultures and countries, if we just pay attention to this rectangle here, is the willingness to donate. Sarah Davison is in our department, and she published this data in 2014 among Canadian First Nations people. Willing to donate one kidney while alive to a family member was as high as close to 70%. Whereas again in Nigeria, this is about a quarter of people who were willing to donate a kidney. So there is need for education to address the knowledge gaps about kidney transplant in many of low-income, lower middle-income countries. And when we look at outcomes of kidney transplantation, I think it's important to point out that at the end of the day, if patients are well cared for, the outcomes are not very different. 5-year patient survival for living donor kidney transplant in the US is 87%. In Brazil, it's 91%. In South Africa, it's 83%, which is a bit low. and in India, it's 85%. So there is a lot of similarity, but where these services are available, patients are able to achieve good outcomes at the end of the day. And in Canada, again, 5-year survival, well, this is graft survival, unadjusted in adults living donor kidney transplant. It's close to 90%, about more than 90% for those aged between 18 and 44, and more than 92% for those between 45 and 54, whereas it is lower for deceased donor kidney transplant, as we know that usually is what happens. So having given us this background, as it were, so that we understand, what happens in different countries in terms of barriers that they face, challenges, cost. As Aminu mentioned earlier, the Global Kidney Health Atlas has been designed to assess availability of key services, how accessible those services are, where they are available, and how affordable they are in countries where they have this. We have had 3 iterations of the Global Kidney Health Atlas. This last iteration, the 2023 version, was released just 2 months ago in Thailand at the World Congress of Nephrology. And the findings of these atlases have given a good picture of what happens in different aspects or modalities of kidney care. We look forward to the 2027 atlas, and we hope we will have good modifications to be able to provide good and high quality data at that time. I mean, already mentioned this, the atlas used 2 methods, a desk research method and a question or survey method to be able to assess data from different countries. For the desk research, we used databases, registries, observational studies where registries are not available for countries. We use the observational data or reports from those countries. Of course, this created gaps because not all countries have registries. Similarly, not all countries have observational reports about availability or quality metrics of kidney transplantation. And for kidney transplantation, we looked at incidence and prevalence of kidney transplantation in countries. For this survey, we emailed 3 persons per country, a leader of Nephrology Association, a policymaker who is head of a hospital, director of health in the Ministry of Health, or anyone who sits in the ranking of a policymaker, and a lead of patient advocacy group. For instance, the National Kidney Foundation, and in other countries that have kidney foundations, we identified such a person who is not a doctor to be able to give a perspective that is different from what a nephrologist and a policymaker might provide. And the data we featured were focused on the number of transplant centers, which were then corrected per million population for each country, funding and cost of transplantation, availability of workforce for transplant, availability of medications, and availability of registry and reporting of outcome. This first slide is data from the 2019 Atlas, I would say, for which we had data from 155 countries who responded to the Atlas, to the kidney transplant questions, and the distribution is, as seen, about the same: 88% high-income countries, 85% upper middle income, 88% low-income countries. But there was obviously a skew towards nephrologists being the ones who responded mostly to the survey. Most of those who responded, 82%, were nephrologists, non-nephrologist physicians, 7%, and other health professionals, 2%, where we couldn't contact a nephrologist or a physician, and 5% administrators, civil servants, or policymakers, and only 3% of patient advocates group. When we look after availability of centers that perform kidney transplantation, again, we see where we see data not reported, it's often because data is not available. in these countries. So again, we find that many of these places fall within Africa and Southeast Asia. And if we look at Canada, centers that perform kidney transplant will rank to between 0.2 and 0.4 per million population in Canada. The deep blue color, obviously, are the ones who have higher number of centers for kidney transplantation. When we look at the global prevalence of kidney transplantation, we find, again, go more towards the teal color, we find that that represents higher prevalence. So Canada has more than 492 kidney transplant patients per million population, same in the US, same in Mexico and Australia and most of Western Europe. But then again, when we look at Latin America, most of Africa, we don't have data for them and in areas in Southeast Asia. Again, similarly, global incidence of kidney transplantation, very high in the high or rich countries and very sparse in countries of low income group. I think just to point out that South Africa and Egypt are the two countries in Africa with leading kidney transplantation services within the continent. The different poles of Africa, Northern Pole and Southern Pole, these two countries are the leaders in kidney transplantation in the continent. But you'll notice that most sub-Saharan Africa countries, data is not available for them because kidney transplantation either does not happen there or happens very sparingly. We couldn't plot this graph or this chart for the 2023 Atlas, so I apologize if I'm taking us back 4 years, but it is a very interesting chart that shows the relationship between kidney transplants per million population and, excuse me, the GDP of a country. And what we notice here is the USA has, of course, and China, they have the highest GDP in the world. And they have, this is a log scale. We really couldn't fit this into a normal scale chart because you'll find a country like Myanmar with a kidney transplant per million population of about 0.02 compared to the US that runs to probably around 98 or something. And in Canada, we find again, a high. So a lot of the countries we'll find on this part of the chart are countries that are rich countries and are able to perform more kidney transplants. But there are some rich countries, as it were, and there are some reasons why, again, countries like Kenya, Nigeria, I'm not sure what IDN is, I'm not sure if it's Indonesia or something, but that have high GDP, but have very low per million population of kidney transplant incidence. When we look at the incidence of deceased donor kidney transplant and living donor kidney transplant, it typically follows, again, the same pattern that we see earlier. We saw earlier the rich countries, the areas where these services are available for deceased donor kidney transplant, and whereas in lower income countries or middle income countries, we find like these are sparingly available. High income countries are the ones who are able to mostly perform deceased donor and living donor kidney transplantation. Low income countries, based on our data, could only perform living donor kidney transplantation. And there is no country where only deceased donor kidney transplantation takes place. Again, incidence of preemptive kidney transplant. This is what we're able to identify with a lot of graying areas across. It is possible that there are countries that have or are just beginning a preemptive program of kidney transplantation. But based on our data, this is what we find: North America, most of Western Europe, and the rest of the continent of the world sort of grayed out with no data available for them. When we look at waiting list in low-income countries, there are many countries, over 80%, that do not have a waiting list. And those who have usually only have a regional list, whereas in high-income countries, there is a national list of kidney transplantation, some regional, and very few that do not have. And again, timely access to operating space. Only 2% of countries in low-income countries say they have that, compared to these different proportions across other income groups. Availability and monitoring of immunosuppression, which is a key aspect of kidney transplantation. Many low-income countries, only 9% said they readily have available immunosuppression and anti-rejection treatment, and 14% say they have availability of facilities for monitoring the levels of immunosuppression. And we can see a stark difference between these income groups: high income, low income, upper middle income, low income. And again, availability of standard organ procurement frameworks, which guide how organs are to be procured. Many low-income countries, in fact, no low-income countries reported having this. Only 13% of lower middle-income countries have procurement frameworks, compared to higher proportion. Even among high-income countries, it's kind of not encouraging that only 48%, well, of this proportion, many of them more have, but have compared to the other income groups. And when we look at funding for kidney transplant medications, we looked at different models of funding for kidney transplant medication. But for funding generally, we looked at publicly funded by government and free at point of delivery, publicly funded with some fees, a mixture of public and private funding, solely private and out-of-pocket payment systems, and so on and so forth. We find that in low-income countries, the higher proportion of countries utilize solely out-of-pocket payment system for kidney transplant medications. And whereas in high-income countries, there is a high proportion of countries that use publicly funded methods for payment for transplantation. And the same thing is also seen when we look at the kidney transplant surgery itself, where many countries that are low income or lower middle income use solely out-of-pocket system payment for surgery, which is different for what we see for publicly funded by government and free at the point of delivery. When we look at their capacity to measure and monitor or report patient and graft outcomes, again, it's the same pattern we tend to see all across. When you look at it in terms of high income, lower middle income, upper middle income, and high income countries, high income countries do well. Of course, we expect that hopefully with these reports of our atlas, that future atlases will show 100% of high income countries where kidney transplant services are available, being able to report all of these measures of both patient and graft outcomes. And when we look at availability of health information systems and the spectrum of data they collect, no low-income country features on this chart, but we find lower middle-income countries mostly reporting hospitalization, few with a kidney transplant registry compared to high-income countries, just about 16% of lower middle-income countries. Something else we did in the current atlas was to look at changes between 2019 and 2023 in terms of countries that participated in the 2019 survey and countries that participated in 2023 survey. And one of the things we found was overall, and which is quite positive for kidney transplantation, overall kidney transplant centers across the world have increased by almost 7%. In some regions like Africa, it's sort of stayed static or slightly reduced, but in other regions like Western Europe, it's gone up a lot. And in there's another region where it went up. I think for most other regions, it sort of dropped, except Western Europe. And I think that number is what drives this 7% increase. And we looked at this again in terms of income group, low income, lower middle income, upper middle income, and high income countries. We also looked at the prevalence of kidney transplantation, that the number of people who have been transplanted per million population. This has increased by almost 10% from 255 per million population to 279 globally. And again, that number marginally increases in Africa, in Latin America, in the Middle East, and Western Europe, and so on and so forth. And finally, we looked at availability of public funding for kidney transplantation that is free at the point of delivery. This has gone up by 16% worldwide, and with various degrees reported across regions. There are several limitations to the GKHA survey. The one is that it relies heavily on a questionnaire survey, and this could introduce bias on knowledge, on expertise, on perception of the questions asked to the respondents. Most of the respondents were nephrologists, but so we hoped that there was a good understanding of the questions asked of them. There may be elements of subjectivity because of social desirability bias, where a person doesn't want their country to look too bad and therefore maybe inflate numbers or deflate numbers to make things look good. One of the things we did to ensure that this was not the case was to get the regional board chairs to look through all the data from each region and to be able to guide us whether there were regions that were falling far off from what is typically known of them. We're also unable to ascertain data within country variability. For instance, Canada is a country with a spread of over 5,000 kilometers. What happens in the East Coast and the West Coast may be different from what is happening in Manitoba. We just assessed Canada generally as a country, and the people who responded for Canada were able to give us a good idea of what is happening in the country. For the desk research, this is a limitation because in many instances where countries did not have a registry, what was available, published data was what we used, and we used the most recent data that was available. So while the USRDS, we're using 2020 data, 2021 data, there are some countries in Africa or even in the Caribbean or Southeast Asia where data was only available for, say, early 2000s or mid 2000s. So that sort of was a limitation. And it was also, we were also unable to provide kidney transplant estimates from many low-income countries because there was lack of rigorous data from many of those regions. And you will notice that the chart I showed earlier, some of the maps I showed had gray areas because many countries do not have reporting, and therefore we do not know if they actually truly have a kidney transplant program and so forth. And again, as I mentioned, the predominance of nephrologists responding sort of may create some sort of limitation because and it's a strength also for the study because they understand what is happening in their countries and region, but many people may look at that as a limitation. And finally, there are no data about comorbidities like prevalent rates of diabetes, hypertension, which could be different in different parts of the world and may have contributed to the variability in disease, living, and preemptive kidney transplant rates. But despite this, we still feel that the Global Kidney Health Atlas surveys provide a good framework or picture or overview of what is happening regarding kidney transplantation around the world. And these resources need to be used, and which is what the ISN is trying to do, especially in Africa, in Southeast Asia, to try and use these to galvanize governments to do more for ART. So in conclusion, the ISN-KT study provides estimates on the capacity of kidney transplant across countries and regions. So many challenges to kidney transplantation, including underutilization of deceased donor organs and financial constraints. play a big role and should be addressed through education and advocacy. There is inadequate funding for healthcare, post-state of health infrastructure, which I know I didn't really talk about this. We do have data on it, but we can go on and on talking about so many things. And healthcare system designs are significant barriers to improving access to quality of kidney transplant, especially in low-income and lower middle-income countries. There is need for government-backed initiatives that are tailored toward improving organ donation and use of updated legislation on transplant policies, especially in low-income and lower middle-income countries. And there is high-income countries need to address peculiar challenges like low public awareness. The data I showed earlier for Canada from Sarah Davison in First Nations people showed that there was reduced knowledge among that population in terms of what kidney transplant is all about and their willingness to donate a kidney. And like I mentioned earlier, these studies provide a framework to engage policymakers to improve kidney transplant services worldwide, including in Canada. I want to thank you all again for the opportunity to be invited to present our data. Thank you very much. I'll stop here.
Thank you so much. I mean, what a tour de force in gathering all of these complex data. Do we have questions from the audience? I might just start by saying, well, first of all, thank you for presenting this. It's very compelling data and very complicated. What do you see as the most encouraging? Well, you know, the issues are so complex and so different from place to place, and gathering these data is just, of course, one but very important part of looking at it. What do you suggest are perhaps the most encouraging ways where differences could be made moving forward?
No, thank you. I think one of the slides we showed that, although very marginal, I think it was 16% of countries that were now making public funds available for kidney transplantation. When we looked at those countries from 2019 and 2023 that participated, that had gone up by 16%, which is great that there are countries where the government want to use public funding to address, issues of kidney replacement therapies and transplantation. That is encouraging. Unfortunately, many of those countries are in upper middle income countries or high income countries that was not happening in before. So the discouraging element of that is that in areas where these services are highly needed, like in Africa, which I showed a lot of data about, there was only like a 0.3% increase in the number of countries that allow public funds to be used for kidney transplantation. So that is discouraging, but we hope that, with this data available, we can use it to push for advocacy and engage governments in many of these countries. So just one final point. Aminu mentioned earlier that the ISN has been working with the WHO, where the WHO can see these data that we have. We gathering it for the ISN, but the ISN can show this to WHO, and they can begin to be the ones to push governments to do more in terms of funding, whether for hemodialysis, PD, kidney transplantation.
And for transplant, we've been working with the ISN to support countries in low-income nations to develop policies and frameworks to guide kidney transplantation practice, which predominantly in the past has just been individual center effort, but now are being done increasingly at national level.
And do you see a role for example, I know the Transplantation Society has been active globally, working in partnership with WHO. Do you see additional ways where that could be helpful?
Well, yes, there are many ways where that could be helpful. The Transplant Society in Canada, I believe you mentioned, they could partner with the ISN. ISN has different programs where they reach out to low-income countries, lower middle-income countries where certain services can be provided. In fact, service as so small to us here, but it's a big thing there, where you organize a Zoom lecture to talk about setting up a transplant program in a low-income country. That's a big thing because they will be gaining from the experience of people who have been doing this for many years. But even beyond that, creating opportunities maybe where people can, either surgeons or physicians can come and train, can be something that is valuable to people in many of those countries. So I think the best way that this can be done will be to partner with the ISN and with the Transplant Society as well. I know the Transplant Society and the ISN have been working together to help many countries in Africa. Unfortunately, sometimes these things fall off the cliff.
Exactly. And something related is the ISN Renal Center program. So obviously we're going to have a ISN Transplant Society Renal Center program, where a big center in developed world, like University of Alberta, will support a center in Africa, for example, or Southeast Asia to help develop their transplant program.
Yeah, I think some of these partnerships, these creative partnerships, and training opportunities for individuals to exchange training programs and internships and so on can be very useful and have been shown to be useful in other ways. I'd also like to acknowledge, I think, we have a question in the audience, but I think, do we note that there are a number of individuals perhaps from Nigeria who are attending remotely just now? Some of your colleagues perhaps are listening to you from Nigeria. We do have a couple of questions. Is there any estimation of people emigrating for the purposes of accessing renal replacement services when their home country doesn't have such services available? Also, how much is transplantation purely for people of means in many parts of the world where public health insurance is not available?
Thank you very much. I'm not sure we have like a good estimate of people emigrating for the purposes of accessing transplant. In many of the countries, again, if you remember the one slide I showed about healthcare spending per person, I think that tells a story of what is available for healthcare. So many people who would travel outside of, for instance, Nigeria or somewhere in Africa, Congo, to go and access transplant in the UK or in Canada or wherever they want to go to, are the rich ones, are the people who have the funds to be able to do it. If somebody's annual minimum wage is less than $1,500, there is no way you are going to travel to go access kidney transplant. So unfortunately, we don't have that estimation, but that's a good question, Aminu, for us to consider for the next atlas. To include that, maybe that will sort of give a good picture. The second question is, how much is transplantation purely for people of means? Well, that's what I just described. It's only for people who have the funds to be able to do so, who are able to access it.
Yeah, that sounds like it. Well, we're out of time. I want to thank you again for a really thought-provoking overview here, and congratulate you on the continued work that you're doing in this regard. And we look forward to hearing more as this continues on with the ISN. So thank you so much. Today's session is the end of the seminar series for this academic year. We'd invite you all to please, if you haven't already, subscribe to our Transplant Times newsletter so you can be informed of sessions that will be starting in September. We have a number of sessions and speakers already lined up. If you have suggestions, please, as to topics you'd like to hear or speakers you'd like to hear, please do let us know. You can email, I think we've got the email in the chat. And we wish you all, we thank our speakers today again. Thank you for the audience for your engagement, and wish everyone a very wonderful summer, and see you in the autumn.
Thank you. Thank you very much.
Thank you. Bye now.